Okay, so we'll get started here this morning. Welcome everybody. My name is Hannah O'Loughlin. I'm the new chair of the Education Committee. And as MIRTPs, we've had our fair share of challenges over the course of this pandemic. So the Education Committee is really pleased to welcome Dr. Kim McMillan, an assistant professor in the School of Nursing at the University of Ottawa, to deliver a presentation for us and discuss the impact of change fatigue on healthcare workers and also how they relate to our job performance and our patients overall. So please welcome Dr. McMillan.
Good morning, everyone. Thank you so much for the invitation to speak at your AGM today. Before we begin, I just wanted to start by paying respect to the Algonquin peoples, who are the traditional guardians of the land in which I am coming to you from this morning, here in what is now known as Ottawa, Ontario. So as mentioned, my name is Kim McMillan. I'm a prof here at the School of Nursing at the University of Ottawa. My clinical background is pediatric oncology, and I've been invited here today to talk about the concept of change fatigue, which is more so what my PhD focused on. So first and foremost, I wanted to start things off with this quote to see if it resonates with all of you. I'm going to read it, then I'm going to have you all participate in a quick poll. So here's the quote. "Oh no, not another thing. Years and years of change for all the staff. It just hasn't stopped. We just haven't gotten our feet back underneath us." So my question is, does this resonate with you? And I know that there's a polling function, and I'm wondering if we can use that now to ask that question. So does the concept of change fatigue, does that quote resonate? So it looks like the poll is open. As the results start coming in, I'll just ask for those results.
They're still coming in.
Perfect. And as they're coming in, this quote is actually an example of change fatigue noted by a nurse that I interviewed in 2015 for my PhD research. But change fatigue still exists today and is especially important to consider in light of how fast things continue to change and evolve in our day-to-day work as it relates to the COVID-19 pandemic.
With 91% of the votes, 60% say yes.
Okay, yes, so it does. It continues to resonate today. So today what I want to do is discuss why I decided to explore how change was experienced by healthcare professionals, what change fatigue is, and how change fatigue impacts healthcare workers and patients. I will briefly tie this all back to the current context of how we're navigating the COVID-19 pandemic and explore ways that change fatigue can actually be mitigated, because it can, it just needs a little work in doing so. So how did I even wind up studying this idea of change fatigue? Well, I'd been working as a registered nurse at a hospital here in Ottawa that was undergoing multiple changes in a very rapid period of time. Within a span of 2 years, we had 2 sets of new IV pumps, new narcotic pumps, new electronic charting, new electronic medication cabinets, and collectively those all completely changed how we carried out our work. And those were just the technological changes. We also implemented a new philosophy of nursing care. We implemented lean philosophy hospital-wide and had multiple changes in hospital administration and leadership. All of these started to really transform how I carried out my work and viewed myself as a nurse. I knew the intention of implementing changes comes from a good place. It's always to better support me in my work and enhance patient care delivery. But paradoxically, at that same time, I was taken away from the work I valued most as a nurse, which was being physically at the bedside with my patients and my families, adjusting to new technologies, workflow changes, and to the increasing expectations of nurses resulting from all of these changes caused many patient care interruptions and increasing amounts of time actually away from patient care. Amidst my struggles to adjust to these current changes, more changes seem to roll out that too required periods of transition that were not necessarily reflected in the calculation of my workload. So, I began to resent being forced to use new forms of technology. I resented having to change from paper-based documentation to electronic because retrieving and entering patient care information now actually took me longer than it did to perform the tasks that I was documenting. So, I begrudged being made to reorganize the traditional way of actually performing my nursing care, simply so I could document it in this predetermined manner. I got frustrated working with new IV pumps because I felt like I was spending more time troubleshooting them than actually using them to administer patient medication. I really did struggle to understand some of the rationale for the changes, as I did feel that it just kept taking me further away from direct patient care. My nursing colleagues were experiencing these changes in similar, disheartening ways. The increased workloads associated with all of these changes really took its toll on staff. Staff morale was the lowest I'd ever experienced. Our teamwork suffered. Nurses struggled to complete nursing tasks for their own assigned patients. So, so much that we found it hard to help each other out. And that's very uncommon in nursing, right? We're a team-based group, and we help each other a lot, and that defines us as health professionals. So, I eventually started feeling pretty inadequate because I could not manage my workload while at the same time helping my colleagues and the patients who we all care for and felt responsible for on my unit. Yet we continued to stretch ourselves thin to support each other. We achieved this by self-sacrificing behaviors. We'd skip our meal breaks, we'd skip our coffee breaks, which quickly became the new normal. Malfunctionings and failures of new equipment, new technologies, and workflow processes challenged us in ways that left some of us feeling pretty burnt out, exhausted, and in some cases, apathetic. This apathy arose from seeing no end in sight, as every change had another one close on its tail. This wasn't simply work dissatisfaction I was seeing. It wasn't just burnout. There was something else there, but I just couldn't quite put my finger on what it was. So coincidentally, at the same time, I was also in the first year of my PhD and exploring what kind of research I wanted to do. So it made sense to explore how all of this change was impacting frontline staff who worked in my hospital. So when I started digging around in the literature, as you do when you start doing research, I stumbled upon this concept called change fatigue. It wasn't in the healthcare literature and hadn't really been studied in healthcare yet. It was used in management literature, which primarily discussed, this idea of change fatigue in the private sector, which made the presumption that only for-profit private sectors implement change rapidly and continuously, assuming that sector is more competitive. But when we examine change in healthcare, there's actually a multitude of reasons why changes are implemented at the rapid rates that they are. So when we situate change in healthcare, we know that change is inevitable for healthcare institutions, especially some of the larger scale ones that continuously strive to receive full accreditation and serve, for example, as trauma centers, academic teaching institutions, and who partner with internationally acknowledged research institutes. Hospitals with these affiliations have to adapt, improve, and innovate in response to a plethora of external pressures, which include healthcare policies, legal frameworks, and scientific advances. And I think that came through very clear this year as we had quite an explosion of COVID research that really truly impacted what we were doing and how we did things very quickly in our healthcare settings. These pressures challenge hospitals to strive for patient safety, continuous quality improvement, and the provision of exceptional family-centered care. Attending to all of these pressures requires time, energy, and money. And in order to thrive within these complex systems, hospitals require an extensive amount of resources while still adhering to really challenging fiscal constraints. So this idea of rapid and continuous change creates a push-pull relationship between innovation and a balanced budget. New technologies are expensive and require extra resources. However, simultaneous restructuring efforts see hospitals shrinking other valuable resources in compensation, such as human resources, notably frontline staff. This creates a really challenging workplace for individuals who have to engage in these change initiative activities with limited resources. And as it turns out, often does result in the actual experience of change fatigue. So what is change fatigue? It had previously been described in the management world very broadly as overwhelming feelings of stress, exhaustion, and burnout, fueled by feelings of ambivalence and powerlessness associated with rapid and continuous change in the workplace. My research elaborated on these in the context of healthcare, but also provided a better understanding of some of the contributors to the existence of change fatigue amongst health professionals. The health professionals I interviewed experienced change fatigue as exhaustion, apathy, burnout, and powerlessness, but they also believed that the intensification of nursing work and repeated and ongoing self-sacrifice during these periods of change directly contributed to the experience of change fatigue. So we'll now explore each one of these in a little more detail, then discuss some of the implications of change fatigue for healthcare professionals and patients. And while we work through these ideas and concepts, keep in mind that many healthcare professionals, including within your specialties, generally report proportionately higher levels of stress, exhaustion, and burnout when compared to other professions outside of healthcare, which serves as a problematic baseline that rapid and continuous change only serves to exacerbate in our workplaces. So when we look at exhaustion, many participants recalled experiences of exhaustion, noting it was just really tiring. It's just sort of one change after another. It really tired people out. Staff really felt exhausted, noting, there's only so much an individual can absorb. There's only so much you can learn. There's a level at which sometimes it's just overwhelming because you're expected to know so much. The rapid rate at which changes were implemented meant that staff had to learn a lot of new things very quickly, which included the technological components of a lot of new equipment. These repeated feelings of exhaustion altered nurses' perceptions about change in their workplace, with one nurse telling me that, we've seen a lot of change. Therefore, our perspectives on change is very different because we get really tired of it. In light of this, they were now skeptical of changes, questioning, do we really have to do this now? And making remarks such as, oh, here we go again, another change is not going to work. What participants noted was that often the changes seemed really rushed and did not have what they believed to be the adequate foresight for them to be successful. This resulted in repeated failings of changes and this sort of slew of retroactive accommodations to remedy the failures, which once again increased the amount of work staff had to put in to make these changes work. What this resulted in was, as one participant told me, people aren't trying as hard. Everybody is a little bit exhausted and a little bit done. Participants were exhausted in part because of the stress that accompanied the change. All of the changes were really stressful for staff, with another participant telling me, if you're working on a unit and those changes are coming one after the other and you've got to deal with them on a daily basis, it's hard. It feels very arduous. Participants were not only exhausted from the impact of the changes, but also how the changes repeatedly unfolded, which was notably a top-down approach with little involvement of frontline staff in that process. Nurses did not perceive change as a collaborative activity between leadership and frontline staff. they felt changes were being put on them, which also contributed to their feelings of powerlessness, which we will return to in a few minutes. The exhaustion participants spoke of was also exacerbated by the loss of what some of them called lulls. So these periods of time that facilitated recovery, either after a change or after a very stressful period at work. These lulls included periods of time such as summer and Christmas. These lulls were times when the hospital seemed less busy and the overall acuity of patients was lower than usual. One participant described the loss of these lulls in relation to increasing patient acuity, saying, it would be nice just to have a lull for a while. We don't get our summer lulls like we used to, and that's a huge change that we actually haven't even recognized. The illnesses that are out there, the acuteness of them is so much higher. This particular participant used the example of respiratory season to situate the loss of these lulls, recalling that respiratory season used to just be during the winter months, but now it's all year long. During respiratory season, which was now all year, the intensity of the work was very high and patient acuity was also really high. Nurses looked forward to those lulls to recover from those peak periods, but they no longer seem to exist. And nurses experienced these change initiatives within really complex systems. Yet, when we looked at the structuring of change initiation and implementation, such things as patient acuity, changing patient populations, and increasingly complex demands of patients seem to be overlooked in the change process. Participants were unable to manage rapid and continuous changes when there were no longer these periods of lulls, or even that, as one participant told me, that bit of downtime just to have a giggle, right? These lulls and periods of downtime allowed nurses to depressurize and recharge in prep for busier peak seasons associated with, for example, respiratory diseases, which accompanied really high stress work environments and heavier workloads. Lulls also provided nurses the time they needed to adapt to changes, as more time could be spent learning new workflow processes and troubleshooting new technologies. Those lulls were described by one participant as what keeps us all sane. Without those lulls or recovery times, however you want to phrase it, rapid and continuous change led to the emergence of apathy, burnout, and feeling voiceless and powerless in their work environment. So when we look at the idea of apathy, some nurses described being numb to changes, noting, one nurse said, you become numb to the changes that are occurring at the institution. You're like, oh, well, it's just another change. Let's keep going because we have to get our jobs done. Apathy served as a protective mechanism. Nurses really had to pick and choose what aspects of their work they could mentally and emotionally invest themselves in. And responding to changes that did not serve them was counterproductive in their attempts to preserve their own well-being while they worked through these rapid and continuous changes. One participant described her experience of numbness, suggesting that nurses were becoming robot-like in response to rapid and continuous changes. She said, it's like you've become a robot. You become numb to the fact that you should even question the changes, and you're not encouraged to question the changes. You're just told what's going to happen and to get on with it and keep going. I find nurses are just becoming numb. Other nurses felt the need to disconnect from their work environment in a sense that, there's so much happening, people stopped caring about the changes. Rolled their eyes, oh, here we go, another change. And the rationale for this behavior was that there had been so many changes, participants felt if they got excited or frustrated over every single change, it would drive them to distraction. Some participants also became apathetic to consequences of rapid and continuous change because they felt powerless to do anything about it. For example, repeatedly missing their breaks. One participant recalled often being told by her manager, today, no breaks, guys. And she recalls just taking it, and she was unable to articulate why this had become the norm. saying, I don't know why, we just take it. We know very clearly in the research that work cultures in healthcare that do not facilitate the consistent taking of breaks report higher rates of work dissatisfaction and burnout, which does help to explain the level of apathy and burnout these participants were experiencing. So speaking to burnout, participants made multiple references to burnout in relation to rapid and continuous change. Burnout was both the result of ongoing change and the accompanying increasing workloads, as additional resources to support staff often did not accompany these changes. There was an expectation that staff would simply adapt to the changes while managing the same workloads. However, as one participant noted, this fostered a culture of doing more with less, whereby this participant said, it's physically not possible to do more with less. Everyone is working flat out. I just don't see how we can do more with the little that we've been given. As a hospital, we are struggling with all of the changes. Every department is stressed. Every single department is under pressure. Attempts to keep up with multiple changes under such pressure foster burnout, with one participant saying, we keep trying to keep up and it's burning everybody out. The volume of change resulted in nurses consistently being overworked, which again led to burnout. Consistently being overworked and subsequent burnout contribute to, in this case, it contributed to some units no longer being able to function. And when I say that, what manifested in some instances were spikes in safety reports being filed, which includes the reporting of unsafe work environments for staff, so staffing shortages, and an increase in medication errors, near misses, and other safety incidents directly involving patients. These were often related to the malfunctioning or the inability to troubleshoot newly implemented technologies such as IV pumps or medication administration technologies. Burnout was also intrinsically related to ongoing and prolonged self-sacrifice. Sacrificing breaks was how nurses were ensuring that all of their work was still completed within their allotted shifts. And I'll return to this idea of self-sacrifice in a few minutes. Things that contributed to the increased workloads included increased time to chart on electronic charting files, challenges with the medication administration cabinet, so jamming, absence of prescribed meds that should have been in the cart, and long lineups to access these cabinets. And in addition to troubleshooting new IV pumps. Amidst this, participants still felt ethically committed to engage in meaningful ways with patients and their families at the bedside, which they believed was now viewed as luxury, and did this work in exchange for their breaks. Participants would sit with patients and families in their rooms and talk and answer questions and comfort families when needed, but said that without sacrificing their own break time, they no longer had the time to do this important nursing work, as that time had now been redirected to managing all of the changes. The cost of this self-sacrifice was detrimental to nurses. Nurses didn't have the energy left to care for themselves, which contributed to burnout. And one nurse told me, you need to give so much of yourself at work. And then when you feel like you need a bit more energy for yourself, there's nothing left. There's not enough to cover all your needs. Sorry, my dog has a very loud toy. Now, powerlessness. Participants felt both powerless and disempowered in their practice as a result of rapid and continuous change. Participants felt powerless in the decision-making process associated with change initiatives. For example, one participant told me he felt powerless because leadership wasn't getting the nurses' opinions or including them in the decision-making. All participants lamented that they were not properly consulted about changes. Many participants recalled being given the opportunity to provide limited input, but they really felt that their input wasn't utilized. They believed that they were asked for their input to sort of tick a box that said this group of health professionals was consulted. But they didn't really believe that there was intention of using that input in the decision-making process. So what this meant for participants was that they didn't feel powerful. Yet, at the end of the day, they're really the frontline people that had to implement and navigate all of these changes and all of the challenges with the changes. Participants felt that the lack of involvement in that decision-making took away any kind of power, and power in a sense of, really feeling like you're a part of the team. Participants felt that there was too much very sort of top-heavy decision-making going on and not as much bottom-up control. Participants who felt powerless believed they'd been ignored in the decision-making process because of their positioning within the institution. And this idea of being low down on the totem pole came up a lot. Nurses also felt that when and if they raised really legitimate concerns about the changes being implemented, they were brushed off as, the troublemaking nurse who is resistant to change. Change resistance is a concept I examined extensively in my research also, and it does tend to be the fallback rationale for why change in healthcare fails. The blame for change failure is often put on frontline staff, and this is a very simplistic and problematic way of addressing change failure. If experienced healthcare professionals have serious reservations about changes, those concerns should be validated and further explored instead of being brushed off as resistance. And when we look again at this broader idea of change fatigue and why it was happening, it was intrinsically related to participants' ongoing and prolonged practices of self-sacrifice. With one nurse telling me, we take it upon ourselves to do the extra mile and constantly do the extra mile, and then we burn out. There's nothing left. So the extra mile consisted of care activities that nurses felt morally committed to provide. So as a result, nurses didn't have the energy to care for themselves. Multiple examples of this self-sacrificing behavior during organizational changes included activities performed both during and exceeding beyond paid work hours. Increased demands on nurses as a result of change initiatives saw them routinely missing breaks or staying late to complete care activities. With one nurse telling me, you're constantly giving the extra half hour or hour every time you come in. You're missing breaks because there's just not enough time in a 12-hour shift to do everything anymore. And to live up to their moral commitments to patients amidst all of these changes, nurses sacrifice their self-care, with one participant blatantly saying, to be with patients, we sacrifice. Nurses felt that to meet all of the care needs of patients, they did need to start taking away their own time at work that was previously safeguarded to try and keep them healthy, which most notably did include breaks. These self-sacrificing behaviors for the sake of patient well-being serve to compensate for these organizational shortcomings that seem to arise during these organizational changes, most notably inadequate staffing and resources. Nurses also sacrificed some of their time away from work, for example, to catch up on emails, with one nurse telling me, I rarely check emails at work. I check it at home. I don't have time to do it at work. I feel like I have a lot of other things to be doing. Carrying out unpaid work activities during non-work hours contributed to resentment, specifically resenting the organization. This was a result of the ways nurses felt that they had to sacrifice their own well-being to ensure patient care was not compromised during these ongoing changes. And one participant summarized it by saying, the fact you don't look after yourself because you're so worried about taking care of your patients and giving them what they need, that you leave yourself behind. It's fine 1 or 2 shifts, but when you keep doing it over and again, it leads to burnout and resentment of the organization. You're just unhappy and you feel anxious and you don't feel like you necessarily want to come to work. It's those kind of negative feelings that occur during organizational changes. When I asked nurses why they continued to engage in these self-sacrificial behaviors, even though they knew it was detrimental to their own well-being, and I think this speaks to not just nurses, it speaks to healthcare professionals. And the nurses said, inherently nurses are caring people, and that's why we keep doing it, and that's why we keep doing what we're doing. We let this happen because we're nurturers and we're carers, and we're still going to nurture and we're still going to care, and we're still going to do our best for our patients because we always do. There we go, intensification of work. So this was another contributing factor to change fatigue. We know that organizational change modifies structures, roles, and procedures of organizations and all of the people within them. It's adaptive and transformative for those who are exposed to change as they explore, learn, and innovate new ways of thinking and working and being in response to these new initiatives. The experience of change includes ongoing and situated accommodations, adaptations, and alterations to our work. Alterations are described as the redistribution of work and responsibility for that work, ways of knowing and doing, and it also changes the collaborative and team working strategies. Small tasks, previously completed successfully and swiftly, now take a lot more time because we actually have to cognitively relearn how to do that work. And we have to make practical accommodations to moderate those changes. This all resulted in the intensification of work for participants. Examples specifically included learning how to reorganize nursing assessments in a way that now fit with a predetermined electronic charting structure, learning how to use new systems and troubleshoot when necessary. Many of the changes these nurses experienced also impacted where they looked for important information. For example, test results, which took time to learn, where they had to now re-navigate that electronic system to find documentation that they actually needed to provide safe, competent nursing care. And these sort of changes impacted their daily routines when they're getting report, giving report, when they're rounding on their patients as well. Changing workflow demands a lot of cognitive attention. That's exhausting when we need to be doing that for a 12-hour shift. In addition to this is the seemingly increased workloads that accompany navigating all of these changes while still having the same patient loads. Things that once took very little time, that we barely even thought about, now took longer to do, which increased stress because it intensified the work that still needed to be done within the same amount of time. Lastly, this intensification of work was further exacerbated by the loss of those lulls, which I previously talked about, which served as a restorative, recharging space for frontline professionals. So what is the impact of all of this on health professionals? Change fatigue, we know, can cause frontline workers to become withdrawn and greatly influences their decisions to leave the workplace and even the profession. I remember one participant told me that she suggested that burnout, as a result of all of these changes, was creating a work environment where she felt collectively that, as a profession, we're edging to the point where there may be some nurses who just say, it's not worth it anymore. Some had ongoing feelings of burnout that left them questioning, why did I even become a nurse? Is this what I want to do for the rest of my career? Many considered leaving the institution or the profession in light of this sort of bombardment with changes. In nursing, we already have a terrible shortage and a very high percentage of new graduates choosing to leave the profession within the first 5 years of their career. So the experience of change fatigue only exacerbates these pre-existing concerns. And this is no different in the imaging and therapy professions. The research to date suggests that, for example, medical sonographers experience silent burnout. That's not talked about and it's not researched. A 2021 synthesis of the literature on burnout in sonographers suggests high rates of burnout are experienced in light of increased scan numbers or work hours per week, working in a hospital setting, and chronic exposure to emotionally stressful situations. A 2021 systematic review on medical radiation science found that health professionals working in radiation science, which includes imaging and therapy professionals, experience moderate levels of burnout and suggests that workplace stress needs to be mitigated to avoid that burnout. Rapid and continuous change can, and often does, foster even higher levels of workload stress. So it's an important thing to pay attention to when we look at evaluating the well-being of employees. We need to start associating that with how much change is going on in the organization. Change fatigue, as mentioned before, occurs when work is intensified, which usually means more time focusing on mastering adaptations to our clinical practice required by changes and less time engaging with our patients. This impacts what we call our relational practice, which is the time we take getting to know our patients and supporting them in whatever ways they need. You know, when we're burdened and distracted by multiple changes, we're distracted by technology even when we're present in the room with patients and families. You know, I had one participant tell me that even though she was physically in the room with her patient, mentally all she could think about was all the charting she had to do on her other patients. Other participants said that, you know, the intensification of their work in relation to all of these changes made it harder to see patients as human beings and easier to see them as to-do lists. And that was really heartbreaking for participants to admit. Participants also noted that, you know, in light of the intensification of work, their collegial relationships were eroding, both socially and professionally. Socially, there was less time to foster, build, and maintain relationships with colleagues. Participants lamented that, you know, less time to tell jokes or update each other on their personal lives was gone in light of the intensified working conditions. Most notably, the steep increase in time required to chart electronically. Professionally, there was less time to support and help each other. For example, and I alluded to this previously, one participant recalls how colleagues on her unit would answer each other's call bells all the time and always volunteer to help each other with complex care activities. But now that their workload was intensified, people felt they barely had enough time to complete all of their own work and were less likely to help each other. And so collectively, the detriment here is threefold. So first being, patients can sense our distance, you know, and we see patients when they are most vulnerable, especially in many of your areas where they're requiring imaging, either because they yet do not have a diagnosis and the stress accompanied with that, or they're getting imaging because treatments have failed. And so both of those scenarios are quite vulnerable spaces. And secondly, so our relational practice, the authentic ways we engage with our patients, is one of the most fulfilling parts of our job. It fuels us and reminds us why we do the work that we do. When we lose those moments, the other parts of our job seem very arduous. These relational moments serve almost as a buffer to the tough stuff. And thirdly, the research to date suggests that our collegial relationships serve as a similar buffer. And when those erode, we're less likely to cope with the stressors of our work, which contribute to decreased work satisfaction, burnout, and even increases the risk for poor mental health outcomes for health professionals. So, you know, when we look at change fatigue in the context of the pandemic, which a talk in 2021 is not complete without speaking to the pandemic, change fatigue is very important to consider in the context of the pandemic. The rate at which information is being received, processed, and flipped into new policies and procedures is alarming. And you, the frontline staff, need to keep up with all of those changes, which seems to be a moving target. In addition to this, radiological work in particular is intensifying as radiological procedures are increasing in demand for the effective diagnosis and follow-up of pulmonary diseases during the pandemic, which are often accompanied by evolving policies and procedures, for example, how to triage in emergency situations. There is pandemic-specific research emerging that has found significant burnout and anxiety in the radiology workforce, which includes many, if not everyone here today. We know that for the broader community of healthcare professionals, the psychological distress they are currently experiencing in the context of the pandemic is directly related to rapidly changing policies accompanied by poor communication from administrators regarding pandemic responses, inadequate training, or a lack of understanding about infection prevention and control protocols, and redeployment to unfamiliar practice settings, which all of these can be categorized as rapid organizational changes implemented to manage a health crisis. So then, how do we mitigate change fatigue? In the context of the pandemic, I don't have an answer. The rate at which policies, practices, and procedures are changing is rapid, but it does appear that they are slowing as we are beginning to see the light at the end of the pandemic, as we garner more vaccine supply across the country. What we will need to pay attention to in the aftermath of the pandemic is much bigger than change fatigue. It will be the trauma, the grief, and the mental health implications that health professionals will need to journey through. Support at the organizational and system levels will need to be in place, as it is projected that the impacts of the pandemic on the healthcare profession will be felt for years to come. In a more general sense, outside of a pandemic, change fatigue is mitigated in the following ways. Ensuring frontline providers are involved at all stages of the process and in meaningful ways. Their voices need to be heard and validated. This is done by consulting providers about what changes they believe would enhance their practice and patients' health and well-being. Often those working the front lines are told what changes are going to be implemented, but they're not always asked about what changes they would benefit from in their daily work. When we look at change theory, this is a clear mistake. Change requires buy-in from all stakeholders, and buy-in does not happen readily when people are told they must do something, as opposed to rationalizing on their own that the change is merited and worthy of implementation. Consultation with frontline providers must continue through the change design stage. For example, if new sonographer technology is to be implemented, sonographers should have ample time to test out various designs and products from vendors. Ample time does not mean setting up a vendor fair for one day. Frontline providers work days, nights, evenings, and weekends. And to get the buy-in required for sustainable change, consultation must be maximized to include those working nights, evenings, and weekends. Upwards of 70% of change initiatives in healthcare fail, and poor consultation resulting in a lack of buy-in is one of the strongest contributors to this change failure. Some of the participants from my research recall the potential IV pumps being set up for one day in a room in a wing of the hospital that did not serve patients. So it was quite inaccessible for nurses to get there in the short amount of time needed during a busy shift. This is not authentic consultation and will not result in buy-in from frontline staff, and contributes to feeling powerless when we talk about the changes. We know that change fatigue is mitigated when frontline staff feel validated and heard. We also need ample time to be given training, and additional training should always be available. The same rules of pedagogy that apply to our training programs to become professionals should be applied in our work environments. There are various ways in which people learn, and specifically adult learners, learn differently than children, and those differences matter. And when principles of adult learning are integrated properly into on-the-job training, retention of the training is higher. Learning needs to integrate theory with actual clinical scenarios. Case studies or sims are a great way of doing this. Take, for example, electronic charting, starting with the basics via a scavenger hunt activity, where healthcare staff need to input patient information into various areas of a patient chart. This is a great way to embed theory. Then, a patient sim could be facilitated where documentation is done in real time, right, with the actual device staff are expected to use. For example, mobile workstations or tablets. This also serves as a great way to assess any ergonomic issues that may arise from workstation devices. Or, for example, in the current context of COVID, this type of sim exercise would work to support workflow for cleaning of devices when entering and exiting patient rooms. In addition to the type of training offered, the amount should also be flexible. Some healthcare providers need extra time and practice, and not getting the opportunity to do so causes undue stress in their work during the rollout and implementation phases. Unfortunately, I did see this in my research as a result of denied requests for additional training. Take, for example, 2 senior nurses I spoke to. They were nearing retirement when electronic documentation was implemented, keeping in mind that these were nurses who grew up in an era when they did not even have computers in their home, nor the internet. The technological revolution that they have witnessed in their life has been extraordinary. Yet in some ways, we have left those nurses behind in the dark to fail. There is this expectation that healthcare practitioners have a baseline competency in managing technology. For new graduates now, sure, that's a reasonable expectation. But what about those practitioners with 30 years of experience under their belt? They are a wealth of clinical wisdom and knowledge, and ineffective training and a lack of support for them is driving them into early retirement. Both the nurses I spoke to said that the lack of support during the transition to electronic charting drove them into early retirement. That's a significant loss for that hospital. And then, thirdly, frontline providers, just give me 1 second, I'm so sorry. I'm so sorry, my dog just destroyed something. Puppies. Frontline providers questioning and their potential concerns about the changes need to be validated and taken very seriously. Those implementing the change often know how theoretically things should work, but frontline providers are the ones who know how things actually work within their respective practice environments. They know the intricacies of workflow because they live it daily. For example, in my research, multiple nurses recall being ignored or dismissed when they raised really valid concerns about the inability to override new IV pumps that were being implemented. They were smart pumps, and so what that means is they have hard limits, which means manually overriding for any medication doses or fluid rates were not allowed. During the training, one critical nurse recalled explaining to the trainer the need to quickly bolus patients and adjust drug concentrations on pumps that exceeded drug reference parameters, as ICUs often use drugs for off-label purposes. Her concerns were dismissed. Months later, a patient in her care almost died because of an emergent fluid loss that could not be replaced fast enough on the IV pumps because she was unable to override the pump to bolus the patient with fluids and blood products. This participant directly attributed that patient's near death to the pump. Examples like this further contribute to frontline staff's feelings of powerlessness, as this participant had the foresight to mitigate this emergency, but her clinical knowledge was dismissed in the training that was provided. And then, we need ample time for these change rollouts. Change requires both physical and cognitive relearning. The research on change is very clear on this matter. New workflow processes associated with change requires time. At the broader institutional level, multiple changes need to be paced appropriately to mitigate change fatigue. Upstream thinking is really important in this regard. Leadership and exec should be mapping out changes that might need to occur over a 5-year period and space them out accordingly, taking into consideration such things as peak admission times during the year, so viral and respiratory season, and not implementing large changes at that time. These 5-year change plans should really be presented to frontline staff for their feedback. Take another example. As we all know, July 1st is notoriously the day that all of our new medical residents start their training in acute care settings. And the first few weeks following July 1st should not coincide with large-scale organizational changes, because a lot of us frontline staff, our work is really intensified during that time because we're supporting the residents' transition into the facility. And you know, additional supports need to be in place to support staff as they adapt to workflow. This support can take many forms. For example, augmenting staff workloads during the first month of implementation on all shifts. This works to prevent burnout, but it also allows staff the time they need to adjust to the changes, which are often technological and take a lot more time to relearn, troubleshoot, and eventually master. Augmenting staff workloads decreases the stress associated with change. Change champions, or super users who are supernumerary on all shifts, are an excellent way to support staff learning and troubleshooting. Super users or champions have received more extensive training on the change, for example, electronic charting, and are available to support frontline staff 24 hours a day. They normally work shifts of 8 or 12 hours alongside frontline staff and are designated to a unit for the duration of the change. Most already work on the unit, so they know the flow of patient care, which really helps with troubleshooting. Unfortunately, one of the problems that does tend to arise with the super user role or champion is that if there are staffing needs, they're actually pulled from that supernumerary role very last minute for the shift to provide patient care. So for example, a super user who has an RN designation and normally works on that specific unit would be pulled to replace a sick call. That leaves the whole unit without a designated super user. And you know what actually winds up happening is that super user now feels obliged to still help with all of her colleagues while juggling a full patient load, which is very stressful and creates a very high workload. So pulling super users or champions to fill staffing holes contributes to stress work environments and contributes to burnout. And then lastly, what we need to be doing is evaluating the change implementation at regular intervals and responding to feedback. So sustainability of change implementation in healthcare is really hard to attain, with change failure resulting more often than sustainable change. One of the best ways to mitigate this failure and foster sustainability is to evaluate change at regular intervals. This allows staff to provide feedback and provide suggestions on how to improve the change and support staff adaptation of the change. The timing of these evaluations is crucial. The feedback must be received before staff revert back to previous ways of working. Intervals vary, but at first every 2 weeks to month is suggested, then 3 months out, 6 months out, and annually from there on out. If staff feedback is negative, immediate action needs to be taken. A great way to do this is to invite staff to participate in a focus group to discuss the challenges the changes had presented and allow them to brainstorm solutions. A lot can be learned from staff focus groups, not just in the context of change implementation. Engaging staff in this manner, as it pertains to change, is imperative in ensuring sustainability of the change, but it also works to empower staff, which decreases feelings of powerlessness, which we know decreases the risks for change fatigue. So in terms of some final thoughts, the elephant in the room. All of the mitigation strategies I have just suggested accrue costs, both fiscal and human resources. They do, but in the long run, they are much less costly than burnout and work dissatisfaction, which often results in long-term leaves of absences and attrition, which have many more associated costs, including the replacing of staff on leave and the orientation and training of new staff to replace those who chose to leave the organization as a result of change fatigue. So in closing, I do hope this presentation has been thought-provoking, and I look forward to your questions and further discussion. So thank you very much.
Thank you, Kim. So everybody, you're able to enter in questions into the chat box. So if you have some of those, just enter them into the chat box, and then we'll get to each of them. So I'll just kind of get the ball rolling a little bit, Kim. So I think I know your research was more focused on the nursing aspect, but it definitely resonates with the medical imaging and radiation therapy professionals that we have as members of our college. A lot of the things that you brought up really made me think about my work and just the changes that we've been going through in general, but also with the COVID protocols being constantly changed. So in your research, were you able to find any evidence or any other research that relates directly to MIRTPs, or do you find that there's still room for improvement and further research in our specific specialties?
Yeah, so when I was invited to come and present, I'm very I know that I'm a nurse, and so I really did look outward to the professions that align with your guys' work. There's not a lot of research, and I think it's a big gap. And I think the problem there is that either you get lumped in with radiologists and their research, or your experiences are silenced, which is really problematic. And I think, just because I researched nurses, I just chose that population because I am a nurse. I think that a lot of the research findings that I had could have applied to any frontline provider.
Yeah, definitely. I would have to agree with that. So that's definitely something, hopefully, that will be further researched in our specific area. But I'm just waiting here for Julie, if you have any questions. Okay.
I have a question for you. You gave a lot of concrete examples, which was great. I'm wondering if a technologist or therapist finds themselves in a situation where change is being contemplated or implemented, and they foresee some negative consequences of that on a clinical level, as you had sort of implied, and they had discussed it with their manager, but didn't feel heard and didn't feel that it was recognized, the risks. Would you have any recommendations on what next steps for them to take would be?
Yeah, and I mean, that's always hard, right? Because you are an expert, you know your workflow, and you know your patients better than anybody. So, if management isn't really listening, I would suggest taking it further to either hire exec, leadership at the institution, because at the end of the day, if you guys are foreseeing something that might impact patient safety, the organization needs to care about that. But what I do find is that we have to also sort of be strategic in how we articulate those arguments. So if it is about patient safety, don't sugarcoat it. Say, I foresee the following happening with this change, and the impacts on patients are XYZ. Because they respond well to when we structure it as a patient safety concern or negative repercussions for patients.
Okay, that's very good. I'm not seeing any other questions at the moment, but so I want to thank you, positive comments about the presentation, and I really want to thank you for your time today. It was really enjoyable.
Oh, my pleasure. Thank you very much for the invitation, and apologize for my dog. Oh, the puppy. He devoured things that he shouldn't have. So thank you very much. I appreciate the time.